အားလုံးပဲမင်္ဂလာပါရှင်ပထမဦးစွာကျမတို့ဒီနေ့ပွဲလေးကိုကျမတို့ကျင်းပခွင့်ပေးတယ်ကျမတို့ရဲ့ Managing Director ဆရာဦးစုမြင့်နဲ့ဒေါက်တာချောချောလင်းစန္ဒာဆရာ Thomas ဆရာဦးသမင်းထွန်းနေတကွာကျေးဇူးတင်ထိုက်သူအားလုံးကိုကျေးဇူးတင်ရှိပါတယ်ဒါပြင်ကျမဒီပွဲအတွက်ကိုဖက်ဖက်ကနေပြီးတော့ကုညီပံ့ပိုးပေးတယ်ကျမရဲ့ team members ဒီအားလုံးကိုလည်းကျေးဇူးတင်ရှိကြောင်းဦးစွာပြောကြားလိုပါတယ်ဒါအပြင်ဒီနေ့ပွဲလေးကိုအချိန်ပေးပြီးတော့ကြွရောက်ပေးကြတယ်ဆရာဆရာမတို့နဲ့တကွာhead တော့ပြောကြားပေးမယ်ဆရာကြီးဆရာမကြီးတို့ကိုလည်းကျေးဇူးတင်ရှိပါကြောင်းပြောကြားလိုပါတယ်ဒီနေ့ပွဲလေးကတော့ကျမတို့အဓိကဥတည်ပြီးတော့ပြောချင်တာကတော့ empowering primary care in the early detection of the chronic kidney disease ပါဒီနေ့ပွဲလေးကိုကျမတို့ကျင်းပရတဲ့အဓိကအကြောင်းရင်းက CKD ကဒီ population မှာဆိုလို့ရှိရင်ကျမတို့ stage 3-5ရောက်တဲ့အချိန်ကျမှ diagnosis ရမယ်ဆိုလို့ရှိရင်လူနာတွေအတွက်နောက်ကျတဲ့ဟာမျိုးမဖြစ်သွားရအောင် early detection အနေနဲ့စောစီးစွာသိရှိနိုင်ခြင်းကလူနာတွေရဲ့အသက်ပေါင်းများစွာကိုလည်းကာကွယ်နိုင်တယ်ကျမတို့ဒီ burden ဖြစ်တဲ့ကိစ္စတွေနောက် cost အများကြီးကုန်ကြတဲ့ဟာတွေကိုပါကာကွယ်ပေးနိုင်တဲ့အကြောင်းကိုဆရာကြီးတို့ကဟောပြောပေးမှာဖြစ်ပါတယ်ဒါကြောင့်မလို့ဒီနေ့ပွဲလေးမှာကျမတို့ဒီနေရာမှာဒီပွဲလေးကိုကျင်းပရခြင်းဖြစ်ပါတယ် CKD ကတော့ silent progression ဖြစ်နိုင်တယ်တခြားသော morbidities တွေဖြစ်တဲ့ diabetes hypertension တွေနဲ့လည်းတွဲနိုင်ပါတယ်ဒါကြောင့်မလို့ early detection ကတက်ပေါင်းများစွာကိုလည်းကာကွယ်ပေးနိုင်တယ်ဆိုတဲ့အကြောင်းကိုဒီနေ့မှာဒီ head talk လေးမှာကျမတို့ပြောကြားပေးမှာဖြစ်ပါတယ်ဒါတော့ primary care ကလည်း CKD ဆိုတဲ့နာတာရှည်ကြောက်ကက်ယောဂါမှာအရေးကြီးတဲ့အခန်းကဏ္ဍတစ်ခုကနေပြီးတော့ကျမတို့ပါဝင်နေတယ်ဆိုတာကိုပြောကြားပေးမှာပါအဲ့တော့ကျမတို့ဒီ simple tools လေးတွေအနေနဲ့ကတော့ကျမတို့ဒီနေ့ပေးလိုက်တဲ့ထုတ်ပတ်လေးတွေမှာဆိုရင်ကျမတို့ CKD brochure လေးတွေလုပ်ထားပါတယ်လုပ်ထားတဲ့ထဲမှာဆရာကြီးတွေရဲ့အဓိက focus လုပ်ပြီးတော့ပြောချင်တဲ့ main text လေးတွေကိုကျမ mention လုပ်ထားပါတာဒါပေမဲ့ဆရာကြီးတွေကတော့တိတိကျကျနဲ့တေးချာချာလေးဆက်ပြီးတော့ဟောပြောဆွေးနွေးပေးမှာဖြစ်ပါတယ်ဒါအပြင်ကျမတို့ laboratory ရဲ့ role ကလည်းဒီ CKD လို့ခေါ်တဲ့ကြောက်ကက်လူနာတွေနာတာရှည်ကြောက်ကက်လူနာတွေအတွက် early accurate and the timely diagnosis ရတဲ့နေရာမှာအရေးပါနေတယ်ဆိုတာကိုလည်းကျမတို့ပြောကြားချင်တာပါဒါအပြင်ကျမတို့ကဒီ laboratory test တွေဆိုလို့ရှိရင်ကျမတို့စီမှာအသုံးပြုထားတာက NIMS လို့ခေါ်တဲ့ Laboratory Information Management System ကိုအသုံးပြုထားတဲ့အတွက်ကြောင့်မလို့ပုံမှန်ဆိုလို့ရှိရင်ကျမတို့ဆေးရုံဆေးကန်းတွေကိုလူနာတွေကရက်ချိန်ပြေလို့ပြန်လာပြတဲ့အခါမှာသူတို့သွေးစစ်ထားတဲ့အဖြေတွေတစ်ထက်ကြီးနဲ့ကျမတို့ပြန်လာပြရပါတယ်ဒါပေမဲ့ဒါ SMN ရဲ့အားသာချက်တွေကတစ်ခုဖြစ်တဲ့ကျမတို့ NIMS System ကိုအသုံးပြုထားတဲ့အတွက်ကြောင့်မလို့လူနာတွေအနေနဲ့အဖြေတပုံကြီးယူလာပြီးတော့အဖြေစာရွက်တွေတပုံယူလာပြီးတော့ဆေးကန်းလာပြစရာမလိုပါဘူးကျမတို့ရဲ့ဒီ test ရဲ့ result အဖြေထဲမှာအရင်တော့ previous 3 time results အပြင်အခုနောက်ဆုံးစစ်ဆေးထားတဲ့အဖြေကိုပါတခါတည်းတွေ့ရမှာဖြစ်ပါတယ်ဒီလို NIMS system ကိုအသုံးပြုထားတဲ့အတွက်ကြောင့်မလို့ကျမတို့လူနာတွေအတွက်လည်းအများစွာအကျိုးကျေးဇူးရရှိနိုင်တယ်လို့မျိုးဒီ CKD လို့ခေါ်တဲ့နာတာရှည်ကြောက်ကက်ယောဂတွေနာမက NCD disease တွေတခြား transplant patients တွေမှာကျမတို့ drug monitoring လုပ်ဖို့လိုတဲ့လူနာတွေနောက်တစ်ခါ cancer လူနာတွေမှာဆိုလို့ရှိရင်disease monitoring နဲ့ treatment အတွက်ကိုကျမတို့များစွာလူနာရောဆရာဝန်တွေအတွက်ကောများစွာအကျိုးကျေးဇူးရရှိမှာဖြစ်ပါတယ်ဒါတော့ကျမတို့ရဲ့ laboratory text တွေကိုကျမတို့အသုံးပြုစစ်ဆေးတဲ့ abort architect နည်းပညာလေးနဲ့စက်တွေနဲ့သုံးပြီးတော့ကျမတို့စစ်ဆေးထားရဲဆိုတာကိုပြောချင်တာပါအဓိကတော့ CI 8200ဆိုတာကျမတို့ integrated system မှာသူ့ထဲမှာဆိုလို့ရှိရင်ကျမတို့ဒီ biochemistry ရော immunoassay နှစ်ခုစလုံးပါတယ် set နှစ်ခုဖြစ်တဲ့ CI 8200နဲ့ CI 4100ကိုကျွန်မဒီမှာ mention လုပ်ထားတာပါဒါပေမဲ့ဒါအပြင်တခြားသော chemical biochemistry text တွေ immunoassay ပဲစစ်နိုင်တယ် abort architect နည်းပညာတွေလည်းအသုံးပြုထားသလို Roche analyzer set တွေလည်းအသုံးပြုပြီးတော့စစ်ဆေးထားတဲ့အတွက်ကြောင့်မလို့ကျမတို့ရဲ့ laboratory test တွေက accurate နဲ့ reliable ဖြစ်တဲ့အတွက်ကြောင့်မလို့ဆရာတို့ဆရာမတို့အနေနဲ့ယုံကြည်စိတ်ချနိုင်တယ်ဆိုတဲ့ information လေးကိုကျမတို့ပေးချင်တာပါဒီ test volume ကတော့ကျမတို့ SMN ရဲ့ test volume data 2024 data အရာကျမတို့ဒီ CKD နဲ့ပတ်သက်ပြီးတော့စစ်ဆေးလေးရှိတဲ့ test တွေပေါ့နော်ဒီ test တွေအပြင်တခြား test တွေလည်းစစ်ဆေးလေးရှိတယ်ဆိုတာဆရာတို့ဆရာမတို့ဒီနဲ့လည်းသိထားပြီးသားဖြစ်မယ်လို့ထင်ပါတယ်ဟုတ်ဒါကတော့အဲ့ test volume ရဲ့ data လေးကို2024က data လေးကိုကျမပြထားခြင်းဖြစ်ပါတယ် ဒါကတော့ပုံမှန်ဆိုလို့ရှိရင်ဆရာကြီးတို့ဒီထဲမှာ mention လုပ်ပြီးပြောမဲ့ test တွေထဲမှာတော့ကျမတို့ဒီ renal function UACR တွေလည်းပြောမယ်ဆိုပေမဲ့ဒီ CKD ရဲ့ risk factor တွေထဲမှာပါနိုင်တယ် hypertension အတွက်စစ်တာတွေကျမတို့ဒီ cardiovascular risk factor lipid profile နေနဲ့ test လေးကိုကျမတို့ package နေနဲ့ compact ဖြစ်ဖြစ်လေးလုပ်ထားတဲ့ test လေးကိုကျမပြချင်တာဖြစ်ပါတယ်ဟုတ်ကဲ့ပါရှင်ဒီနေ့ပွဲလေးရဲ့နောက်ဆုံးဒီကုန်းချုပ်အနှစ်သာရအနေနဲ့ကတော့ဆရာကြီးကိုမှာ early detection for the diabetes kidney disease နဲ့ဆရာကြီးဒေါက်တာရဒါမှာ importance of primary care in the early recognition and the management ကောင်းစဉ်ရဲ့ဆရာမကြီးဒေါက်တာဗီမာမှာ primary care အတွက်လိုအပ်တဲ့ vaccination အကြောင်း importance of primary care in vaccination အကြောင်းကိုပြည့်စုံစုံနဲ့ဆက်ပြီးတော့ပြောကြားပေးသွားမှာဖြစ်ပါတယ်ရှင်အားလုံးကိုကျေးဇူးတင်ပါတယ်ရှင်
ကျိုးစုံနှုတ်ခွန်းဆက်စကားပြောကြားပေးသွားပါတော့ဒေါက်တာအင်းမြတ်သူအားအထူးပင်ကျေးဇူးတင်ရှိပါရဲ့ရှင်ဆက်လက်၍အခမ်းအနားစီစဉ်နှစ်အရာ Professor Koko Professor and Head of Endocrinology ရန်ကုန် General Hospital အား Early Detection for Diabetes Kidney Disease အကြောင်းဟောပြောပေးပါရန်လေးစားစွာဖိတ်ကြားအပ်ပါတယ်ရှင်
Very good afternoon, my senior, junior colleagues, distinguished guests, ladies and gentlemen. So it is my indeed great privilege for me to participate in today's SML academic program for the early detection of the CKD in the primary care. So my talks today is for first part is the early detection for primary care physician. So if you look at these data in 2019, see, this is the 10 global risk factor for death. So number one is high blood pressure. In Myanmar, is around about 26% has a hypertension. And then also we look at the glucose. In Myanmar is 7.9% in the whole country. It's a 2025 data from the STEP survey. So if you combine these two, there might be also a problem with the kidney dysfunction. Also, you can see obesity and lipid all are the problem with the death for the 2019. And then, according to the data, the kidney and the kidney failure and CKD most common cause is diabetes at the moment in our country. So hypertension and diabetes are the most common cause of CKD in Myanmar. In the 20 to 40% of people with diabetes have CKD in the whole the world. So this is the main area for diabetes is to prevent the chronic kidney disease and the renal failure. Even though we do know that CKD and type 2 DM very common and very serious, but you can see awareness very low. 1 in 5 people with the diabetes in the United States doesn't know that they have it. Also, 9 in 10 people with the CKD don't know that they have it. So we need to be very careful of these data because of the poor awareness, insufficient screening and diagnosis and access to treatment. These are the barrier for the early detection of the CKD in the diabetes. So diabetes is a strong risk factor for CKD. Increase the risk for the progression to ESAD. So if you look at this one, prevalence of CKD is more than 3 times higher in patients with diabetes than the non-diabetes. So CKD ဖြစ်တာကိုကျွန်တော်က CKD ဖြစ်ဖို့3ဆလောက်ပိုများနေတာကိုကျွန်တော်တွေ့ရပါတယ်။ The risk of ESKD according to baseline EGFR is higher in patients with diabetes ဆိုတော့ဒီ data တွေကအကုန်လုံးပြနေပါတယ်။ Also, the diabetes အလုံးတွေမကပါဘူး။ Diabetes also is connection with the heart failure, CKD, obesity. All are connected. All are risk factor. These are diabetes, heart failure, and CKD are very closely connected. So 58% of patients with type 2 DM has a double in the CKD. Also, 5 times increased risk of heart failure in type 2 DM. And then these are the obesity exacerbate all of these heart issues. So these are the area we have to look at whenever you treat a case of CKD. Also, you need to look at the CVD as well as the obesity as well as the heart failure. So if you look at this one, the slide, life expectancy is reduced in patients with type 2 DM. If you have a type 2 DM, that you are reduced in the life expectancy for 6 years. If you have a diabetes and CVD, you have a 12-year, it is also reduced. If you have an early CKD, you have a 16-year life expectancy reduced in the case of the diabetes. So, the jamlo, general, the DKD detect logo, so I will move to the another topic is a type diabetic kidney disease is definition. So clinical diagnosis or CKD in patients with diabetes based on the laboratory only. The CKD eGFR should be less than 60 or UACR means urinary albumin creatinine ratio should be more than 30 or both. This is the only two methods to detect the early CKD. CKD. ဒါကြောင့်မလို့ကျွန်တော်တို့ကဘာပြောတာလဲဆိုရင်ကျွန်တော်တို့လူတိုင်းကိုကျွန်တော်တို့ဒီ eGFR လုပ်တင်ပါတယ်လူတိုင်းကို UACR လုပ်တင်ပါတယ် we don't do urine RE we don't do urinary microalbumin at the moment now. Okay, we don't do 24-hour urinary microalbumin. Previously we talked about microalbumin. You need to do microalbumin. Now we're not doing. We do only UACR. So you have to be very after the end of the hours, symposium, in your mind, you have for the early detection of the DKD. Number one, we have to do eGFR. Number two, you have to do UACR. I just look at the previous report from SML. SML report right? Look at the lipid profiles at the top of the list whenever they do. And then also A1C also top of the list. But when you look at the UACR only 2,000 melody. 2,000 is very low number for the UACR. So, Palu less or Duria, general diabetes kidney disease, so urine IE looked at it, urine for microalbumin looked at it, general creatinine looked at China Dwabi. Era, today, we would like to put on your mind that UACR and the eGFR is a two only method to detect the early DKD. So eGFR less than 60 or UACR more than 30, you can call upon the DKD and other clinical signs of DKD, diabetes both. If you have a diabetes nephropathy, long-standing diabetes, UACR more than 300, kidney biopsy shows some structural features of the glomerular pathology changes, just like glomerular basement membrane thickening, mesangia, expansion, nodule, podocyte loss, and endothelial disruption. So these are the definition for DKD. But whenever you see a patient with diabetes, there might be two. It might be a DKD. It might be other cause of CKD. You have to be very careful. So the diabetes nephropathy or other cause of nephropathy. So if you have diabetic kidney disease, the albuminemia should be persistent. And then they have a bland urinary sediment. There's a slow progression of the disease. Reduced eGFR associated with overt proteinuria. Other complication of diabetes has to be present. And duration should be more than 5 years. The HDP to the diabetic kidney zero. If they have a very extreme proteinuria, more than 6 grams, nephrotic and persistent hematuria at this urinary sediment eGFR slow progression rapidly falling eGFR eGFR proteinuria machine other complication of diabetes so that's it, diabetes retinopathy. What we if you have a diabetic kidney disease, 90% should have a diabetic retinopathy. So the patient complication retinopathy duration less than 5 years or other family history or other signs and symptoms of systemic disease, there might be other cause of DKD, diabetes CKD in the diabetes patient. That should be an association. So in that case, you need to refer immediately to the nephrologist. This is not the diabetic kidney disease. So you have to differentiate between the DKD or other CKD in the diabetes patient. So this is the slide. This is a very emphasized slide. Number one, to detect the CKD screening and diagnosis for people living with diabetes, who and when to screen. For the type 1, starting from 5 years after diagnosis, yearly you have to do it. For the type 2, starting at the diagnosis, you have to do it. So type 2 so in in SIPA, UACR or EGFR. All right. Type 1 so in no ngani pipi masipa. Ngani pipi masaba. Through the saying yearly sipo to type 2 mari. Or say bale, how to screen the EGFR and spot urine ACR. This is the only two you have to do it for the detection of the CKD. If test positive, what will you do? You have to repeat it and confirm it. We cannot say it's one time EGFR and then one time the spot unit of the uracea. You need to repeat again. Usually we repeat again after 3 months time. It's still persistently, the persistent urine ACR is more than 30 or persistent EHI is less than 60. We can now call upon CKD, diabetic kidney diseases. No, to positive ဖြစ်သွားရင်3လကြာရင်တစ်ခေါက်ပြန်စစ်မယ်စစ်ပြီးသွားလို့တကယ်တော့3လမှလည်းစတိုက်တွေ့နေမယ် persistent urine UCR or persistent EGFR going down ဆိုရင်တော့ကျွန်တော်တို့က this is the case of CKD ပေါ့အဲ့ဒါကိုကျွန်တော်တို့ကဒီ slide ကိုအဓိကပြောချင်ပါတယ် So in most patients with diabetes, albumin are elevated before EGFR decline. So EGFR 60အောက်ကျမှကျွန်တော်တို့ကမဟုတ်ဘူး albumin ကအစောကြီးရဖြစ်နေတာကျွန်တော်တို့တွေ့ရတယ် ဒါကြောင့်မလို့ကျွန်တော်က some people မှာကျွန်တော်စစ်လိုက်တဲ့အခါမှာ EGFR တော့မကြသေးဘူးသို့တော့ uracea ကဒီ positive ဖြစ်နေသူက30အောက်ကို normal လို့သတ်မှတ်တယ် 30 and 300 and more than 300 these are the two areas for the increase in uracea. So uracea is proceeding and the before the EGFR going down. So ဒါပေမဲ့ the increase CV risk က uracea 10ကျော်ရင်ဖြစ်နေတာကိုကျွန်တော်တွေ့ရတယ်ဒါကြောင့်မလို့ uracea ကအမှန်တန်အရေးကြီးတယ် Doing UACR is very much important, even though you do have a normal EGFR. So you have to be very think about. So in the classical model of CKD and type 2 DM progression, the onset of moderate to severe increase albumin precedes the EGFR falling below less than 40. 60မတိုင်ရင်ဒီကသူကကြာနေတယ်10ကျော်တာနဲ့ cardiovascular risk ရှိပါတယ်330ကျော်သွားတာနဲ့ kidney problem တွေဖြစ်နိုင်ပါတယ်ဒါကြောင့်မလို့ကျွန်တော်က UACR ကိုစော်ကြီးလောက်တာဒီအရန်ကိုကောင်းပါဒါကြောင့်မလို့ we measure UACR early for early intervention of the kidney disease ကို recommend လုပ်ပါတယ် so လောက်ကြလားဆိုလောက်ကြအောင်ဖြစ် why is CKD is type 2 DM underdiagnosed if you look at that lack of CKD specific symptom in early stage so EGFR 30ဒီ CKD 30ဒီပေါ့နော်ကျွန်တော်က CKD stage 3ပေါ့3လောက်ဒီကိုဘာ symptom မှမရှိဘူး symptom မှမရှိတော့ကျွန်တော်တို့ကမစစ်ဖြစ်တာပေါ့အဲ့ဒါကျွန်တော်တို့ရဲ့ဒုက္ခဖြစ်ဒါကြောင့်မလို့ there's a symptomatic in the early stage of the CKD. Number 2 awareness there's less awareness ကျွန်တော်ခုဒီနေ့က today is our symposium main thing is awareness of early detection of CKD. This is the awareness ဆရာတို့ဒါတွေလုပ်ကြပါ please do these things. So number 2 under-realization of UACR အဲ့ဒါကို UACR ကိုကျွန်တော်တို့မလုပ်ဖြစ်ကြတာပေါ့နော်ကျွန်တော်တို့ tick လုပ်လို့ရှိရင်ဆရာတို့ don't go for urine microalbumin now you have to tick a UACR it should be more than 30 you have a problem so ဒီမှာကျွန်တော်ကြည့်လိုက်လဲ less than 15% of patient at risk for CKD has UACR test in 2016အရန်နေတယ်ကျွန်တော်လူ100မှာ 16% လောက်ပဲကျွန်တော် test လုပ်တာကိုကျွန်တော်တွေ့ရတယ်ဆိုတော့ only two things albuminuria and EGFR these are the two if you get these data put on this diagram က download လုပ်လို့ရပါတယ် this is a ကျွန်တော်ဒီဟာတွေကကျွန်တော်တို့က KD go heat လို့ခေါ်တယ်ကျွန်တော်ကဒီ KD go heat ကိုထည့်လိုက်ရင်ရပါတယ်ဆရာတို့ကြည့်လိုက် if you look at this one EGFR is still good 105 but UACR is more than 300 you have to be moderate risk even though EGFR is normal you have a risk if you have a UACI positive ဒါကြောင့်မလို့ UACR တက်လာလေသူတို့က even though normal EGFR ရှိတာတော့ကျွန်တော်တို့က risk ကရှိနေတယ် if you have a EGFR 30 and even though albumin is less than 10 this is very high risk so if you look at this one so no you don't not only rely on only UACR or not relying only on EGFR so put on this diagram and then look at how much is a high risk very high ဒါကြောင့်မို့ကျွန်တော်ကဘာပြောလဲဆိုတော့ဒီမှာ EGFR ကြ albumin 10အောက်မှာတော့မှ high risk ဖြစ်နေပြီ EGFR အကောင်း albumin positive ဖြစ်လဲ risk ကရှိနေပြီဒါကြောင့်မလို့ you have to do these two and then put it on that diagram and look at that how much your patient has a high risk for the CVD. So this one is also, we need to emphasize on this one. So, general classification of blue cost go move the we classify based on cost, we classify based on EGFR, we classify based on albumin. I want to TV or G1 so more than 90 join is normal or EGFR 60 to 90, 89 mildly degrees, 45 to 59 mild to moderate degrees, G3A, 30 to 44 G3B, moderate to severe degrees, 12 to 29 G4, severely degrees, less than 15 is a kidney failure, and then G5. So this is the EGFR. This is the albumin. Albumin is less than 30, UACR less than 30, normal or mildly increased A1. If 30 to 299, moderate increase. A3 severely increase more than 300. So you put in this, your patient, when you have the result of the UACR and the EGFR, put it on there, put it on there. If you have a norm, even though normal EGFR, go there, UACR, 30 out here in down screen လောက်ရမယ် တစ်နှစ်တစ်ခါ screen လုပ်ရမယ် and then ကျွန်တော်တို့က EGFR ကောင်းနေတယ်သို့တော့ UACR ဒီ30ကျော်တာနဲ့ဆရာတို့ treat လုပ်ရတော့ treat လုပ်ရမယ်တစ်နှစ်တစ်ခါကျွန်တော်စစ်ရမယ်တကယ်လို့ဒါ normal EGFR and then UACR 300ကျော်ဝိုင်း treat and refer and then you have to do 3 times a year လုပ်ရမယ်ဆိုတော့ဒီဇာတ်တွေကိုကြည့်လိုက်ရင် you put on these all your data on this diagram and you have to do what to do next. What to do next? ဒါကိုကျွန်တော်သိနိုင်ပါတယ် so ဆရာတို့ EGFR ဒီ30အောက်ကိုပြုတ်ကျသွားရင်ဆရာတို့ now even though normal uracea you need to treat and then you need to do 2 times per year. If you have a EGFR 30 to 44 and then UACI more than 30, treat and refer. So these are the diagram. It's very important. You put on your data and you do what to do next. So you have treat လောက်ရမလား screen လောက်ရမလား refer လောက်ရမလား you have to be ဒါကြောင့်မလို့ကျွန်တော်တို့ကဘာဖြစ်လဲ patient ကို risk ကိုတွက်ပါ all patient with type 2 diabetes should be screened for CKD. Risk is higher in those with hypertension or ACPD or family history. Assess both EGFR and UACR. So you cannot rely only on one. So according to this data, EGFR ကောင်းနေလဲ UACR positive ဖြစ်ရင် you have to treat, right? And also you need to look at the risk factor for the CKD. That's the risk factor. Susceptible risk factor is family history, older age. Initiation risk factor is genetic. Also, you have a progression risk factor, male sex, hyperuricemia, dyslipidemia, risk factor. So smoking, ethnicity, hypertension, female say high protein diet, CVD, obesity, hyperglycemia, heart failure, diabetes, AKI, proteinuria, elevated heart rate, and nephrotoxin. These all are risk factor. Whenever you look at the patient with diabetes, you need to look into what these are the risk factor for TKD. These are the risk factor is if you have a poorly controlled diabetes, this is the risk factor for TKD. If you have an elevated albuminemia, this is the risk factor. If you have a poorly controlled blood pressure, this is also a risk factor. And there is also a other comorbidity as well. So you need to look for all these risk factor to prevent the progression of the TKD. So according to pathology, we have a three area: hyperdynamic theory and the metabolic theory, inflammation, fibrosis theory. These are I'm not going to detail. These are the 3 theory for the drivers or progression of the diabetic kidney disease. If you cannot control elevated blood pressure or intraglomeralular pressure by the RAS blocker, ACI, ARB, if you have a problem with the poor glycemic control, and then you have a problem with the progression of the kidney disease. Also, last one is the inflammation fibrosis. This is what we call a mineralocorticoid receptor overactivity. Is going to have a problem with the inflammation and fibrosis of the kidney disease. Tubular inflammation, glomerulosclerosis, and they also go to CKD. These are the mainly 3 or 4 drugs are the main drugs for the prevention of the progression of the kidney disease. I'm not going to detail. Next speaker will be talking about this one. But for hemodynamic, you should be on the ACI and the ARB. For the hyperglycemia, you should be on the GLP-1 and SGLT2. For the inflammation, you should be on the non-steroidal MI, just like phenylenone or spironolactone or alprazolam. These are the main 3 drugs for the to delay the CKD. So this is CKD is a continuum, development, progression, consequence. Even though you can see the normal patient with the diabetes, normal, you have to screen for this CKD risk factor. This is your job. The primary care physician job there. So diabetes, you have to look in for the screening for CVD risk factor. Number 2 stage, if you have an increased risk, you have to reduce the risk factor reduction, just like sugar control, blood pressure control, and then also screening for CKD. And then you have to do the UACR and EGFR at that stage. If you see EGFR is reduced, less than 30, UACI more than 30, and let's say and 30, you have to diagnose it and treat the comorbid, and you have to slow down the progression by giving the SGLT2, GLP-1, blah, blah, blah. If you have a EGFR stay going down, estimate the progression, treat the complication, prepare for replacement, and you have to refer to the nephrologist. And the kidney failure, you go for transplant and death. So primary care is starting from normal up to damage, up to EGFR 30. It's all the patients are in your hand. And later on, will be coming endocrinologists, cardiologists are coming in that stage, and later on, nephrologists will come. So these are the whole process is going to be a cooperation between the primary care physician and endocrinologist. So first part is very much important. In that case, damage, we cannot reverse it. It's very difficult to reverse the decay. So only our emphasized area is the primary care. You need to detect and you need to prevent the progression of the kidney disease. So this is the primary prevention, risk factor reduction. Secondary prevention, treat and comorbid and prevent the CKD progression. Tertiary prevention, prepare for renal replacement therapy. So these are the area you have to go: ACI, ARB, blood pressure, glycemic control, poor restriction. You have to prevent and treatment of uremic complications, just like malnutrition, anemia, osteodystrophy, acidosis. You have to prevent a comorbid, systemic hypertension, cardiovascular, diabetic complication, other comorbid, and you have to prepare for the CKD. These are the program for the whole CKD. So I'm not going to detail for this because this is a 4 pillar. Next speaker will be talking on that one. Okay. So 4 pillar IS system blocker, SGLT2, non-steroidal MI, phenylenone, GLP-1. These are the what we call guideline-directed medical therapy. So you need to start guideline-directed medical therapy, even though you are not nephrologist, even though you are not cardiologist, even though endocrinologist, you can start in the primary care to prevent the prevention of the renal diseases. So if you look at this, if you see SGLT alone cannot all-cause mortality stage, they can reduce. If you combine all 3, there will be more reduction in mortality. But according to data, you can see in case of the CKD registry, ACI 20.6% and SCI PPI or SCLU GLP only 0.2 and 0.07% of the TKD patients are receiving this one. So this is really tragic for our physician, because you have to start. Because in our country, endocrinologists are less than 50. All right, nephrologists are less than 30, and cardiologists are less than 50. So we cannot cover all over the country. So you all are very important for us. Start from this beginning. You have to prevent. So the primary care physician has to be in the patient stage 3 CKD. 84.6% should be managed in primary care. If you have a stage 4 CKD, 57%, and then nephrologists are, and the 28.84% are secondary care, and then later on, there might be more roles of specialists. But in early phase, up to stage 3 CKD, the 84.6 should be on the primary care physician. So this is also, if you see, UACR testing at least annually lower me, though 10 to 40% low day. The jamlu underdiagnosed pinning. ACI Yabi, a young nere, SGLT 30% she non-steroidal MI, phenylenone, they don't know. That's a problem also. So we are talking a lot on the phenylenone for the early treatment of the guideline-directed medical therapy. So this is a paradigm shift. And previously, primary care is only go for weight loss, physical activity, smoking, and then glucose. And diabetologists are doing glucose lowering with the SGLT, GLP-1, lipid lowering, blood pressure lowering, and then cardiologists going for thromboembolic advanced therapy, just like PCI. But later on, our paradigm shift is for reframing the cardiorenal risk reduction. Agents should be reducing CV risk and kidney risk. SGLT should be on the hand of the primary care physician. We are now, SGLT is a little bit far away at the moment, but I can see now a lot of primary care physicians are putting on the SGLT2 for an early prevention of the kidney diseases. So when to refer to specialist kidney care causes, if you don't know the cause of CKD, if you have a hereditary kidney diseases, recurrent extensive nephrolithiasis, you need to refer. If EGFR less than 30, you need to refer. Albuminuria more than 300, and then this is you cannot control the albuminuria and the microscopic hematuria, you need to refer. And also, you are treating the primary care, but CKD and hypertension are very refractory to treatment. Just like you have to put on the 4 antihypertensive agent, and the persistent abnormality of hyperkalemia, acidotic, anemia, bone disease, malnutrition, you need to refer. So apart from that, you can manage by yourself in your hand. So detection of CKD in early stage prior to symptomatic stage is very much important. Also, facilitate early initiation of pharmacotherapy, guideline-directed medical therapy, and facilitate multidisciplinary team management. If you think we do need, you refer to endocrinologist, cardiologist, or nephrologist, and prevent the cardiovascular other comorbid. Facilitate early referral to nephrology and timely initiation of dialysis. These all are needed to reduce the mortality and mobility of the DKD. So my final slide is number 1. When to start prevention? From the beginning, think about prevention of DKD. From the beginning, early detection of the CKD by screening UACR and EGFR. Also, you need to do for A1C. You need to do for lipid profile. You need to do for the creatinine. So these are the things. From the beginning, lifestyle control is very much important. Obesity and DKD are very much important. Later on, we talked last week about CKM syndrome. CKM syndrome, main driver, stage 0 is due to obesity. Obesity, you need to think about obesity. And from the beginning, you have to control the glycemic control. A1C should be less than 7. That's 7. And from the beginning, you have to control the blood pressure 130/80. From the early detection is very much important. So, who should screen? Type 1, 5 years after diagnosis. Type 2, immediately. What should be screened? EGFR and UACR. EGFR, if more than 60 persistently, or UACR more than 30, EGFR less than 60 persistently, and UACR more than 30, this is the diagnosis of DKD. 4, in EGFR is 60, UACR is 3, no DKD, and you are screening and you can control glucose, blood pressure, CBD, and phenylenol if you need it. 30 and 60, CKD present, you refer. And it's less than 30, DKD present, you refer. That is the job of the primary care physician. And when you refer, chronic progressive loss of kidney function, you have to refer. Unable to remain on renal protective therapy due to adverse effects, just like hyperkalemia or more than 30% increase in serum creatinine with 3 months of studying ACI and ARB, you refer. If you are not unable to achieve target blood pressure and glucose, you need to refer. So this is my final slide. So in summary, our symposium is for the early detection of DKD by doing UACR and the EGFR. This is my final message. Thank you so much. Thank you.
အခုလို CKD prevention ကြောင့်ပြည်စုံစွာဟောပြောပေးပါတော့ Professor ကိုကိုအားကျေးဇူးထူးပင်တင်ရှိ ဟုတ်ကဲ့ပါ ဟုတ်ကဲ့ပါရှေ့ဆက်ပြီးအခမ်းအနားစီစဉ်300ဒေါက်တာရာဒါခရစ်နာဆိုတီရနန် Senior Internal Medicine and Principal Investigator Columbia Asia Hospital Malaysia မှာ The Importance of Primary Care in Early CKD Recognition and Management အကြောင်းဟောပြောခြင်းပဲဖြစ်ပါတယ် I would like to respectfully invite Dr. Radhakrishna Sothiratnam to continue our academic session.
Wish everybody a very good afternoon, and thank you, Dr. Kain, for the introduction. I am Radhakrishna. I am an internal medicine physician with a interest in diabetes research. First, I want to congratulate SML Healthcare for organizing this very impressive symposium. I think it has taken a lot of effort, and I'm sure a lot of commitment to help all of us as doctors and practitioners in improving our patients' well-being. And I have to say that it's something of a privilege and an honor really to be back to Yangon after more than 8 years or so. The last time I gave a lecture over here was probably during one of the Myanmar Endocrine Society meetings, and it was organized by my friend, Professor Dr. Tin Sui Lat. So after 8 years, I come back to Yangon. I find this city is really more beautiful than before. And the food is also so impressive. I think I had the best Indian food at Park Royal yesterday. And when I go back to Malaysia, I'm going to tell everybody, you guys better come and visit Yangon. There's so many nice things to see here. There's so many nice things to do here instead of going to other places. So I hope then that, eventually, this is not going to be the last collaboration that we're going to have with SML laboratories. I hope that in future, we will be still able to keep contact with all of you here in Myanmar through webinars and other activities, because I feel that it is very important today. All of you sitting here are the most important people that we need to engage with. And later on, as I go through my presentation, you will realize that you are the most important in the medical profession who's going to make a big difference to what happens to our patients. The decisions are entirely yours. It's not us. It's not internal medicine. It is not endocrine. It is not nephrology. It's not even cardiology. And I first want to thank Professor Koko for doing an excellent job of laying the groundwork, the preamble to what I'm going to speak to you right now. And I must tell her, you must be a real expert. You finished before the electricity went off. Oh, that's remarkable. Fantastic timing. So let's move on. These are my disclosures. So you can see I've done 4 cardiovascular outcome studies. I've done 2 registration studies for ertugliflozin for the US FDA. And right now, my main task is being an external expert for AstraZeneca UK Private Limited in, advising their advisory board in doing a global implementation of primary care physician CKD guideline implementation. So we feel right now that the most important people for us to engage are the primary care physicians if we are talking about CKD. So that's the reason we are all here today. And therefore, my presentation outline is to take you briefly about how you can get involved to detect CKD to protect not only the kidneys, but also to protect the heart. Then we have to emphasize to you the important role that all of you play as primary care doctors in CKD screening. Because if we don't screen now, we are going to miss the boat, and it'll be too late for the boat to come back. And then we want to tell you what are the things that you could do in your own practice to start guideline-directed medical therapy. And last but not least, I want to tell you when is the golden or the most opportune time for you to start SGLT2 inhibitors. Now, we are going to really focus on SGLT2 inhibitors because we feel strongly that SGLT2 inhibitor is a medication for primary care. It is not for nephro, cardio, internal med, or endo. So with that, let me tell you how to protect the kidneys and how to protect the heart and what is your real role. Now, this is some data that I have published from Malaysia. We did the Discover registry for AstraZeneca. And as you can see, these are patients in Malaysia who are failing one oral drug. So they're very early onset type 2 diabetes. Their duration of diabetes is about 2-3 years. But you can see that as early as 2 or 3 years, there is already a high burden of diabetes complications, both microvascular as well as macrovascular complications. And you can see that half of these microvascular complications are all CKD. So in Malaysia, we have a huge problem, and I don't think it is any different from here, because 10 years ago, I remember Professor Tin Sui Lat telling me that the prevalence of obesity and diabetes in Myanmar is more than Malaysia. It's more than Malaysia, and I suppose the data must be about maybe worse after 10 years. The next thing is, we need to tell you a little bit about, not all diabetics are the same. And this publication, which came out of Sweden, tells us that diabetes is a heterogeneous disease. And the only, the common denominator over there is elevated blood glucose. And because it is so heterogeneous, we have got so many different types of diabetic manifestations in people that these individuals have got a varying clinical characteristics, disease progression, as well as response to certain medications, and also the risk of complications. So in the traditional way, where you see in the panel A of how we used to look at diabetes before, so you have a bunch of them, the majority of them who are type 1, and then you have also those who are type 2, and then somewhere in between, and that's the LADA people. And then you have monogenic diabetes, you have secondary diabetes. But if you were to follow an analytical pathway, and you start looking at certain clinical parameters, then you can group them into 5 clusters. So these 5 clusters now, they turn out to be like this. So you've got SAID, which is the severe autoimmune diabetes, and this will include people who are type 1 and those who also have LADA. LADA, is latent autoimmune diabetes of adulthood. So these patients usually present in their older or rather early adulthood. They might look like a type 2 for a while, and then they become type 1. Then you can see, depending on a few parameters, such as your HbA1c, your HOMA-IR, and your HOMA beta cell, your BMI, and your age, you have another 4 categories. So this is a Swedish population. So over there, you don't find that many people who are SIDD. Now, SIDD is severe insulin deficient diabetes. Now, in a Japanese population, you will find a very high prevalence of SIDD because you all know that in Japan, the primary driver of diabetes over there is beta cell deficiency. Whereas, if you now look at the SIRD phenotype, that's a severe insulin resistant diabetes phenotype, these people are probably the South Asians, the South Asian Indians. And in these kind of people, what is driving their diabetes is actually insulin resistance. Then we have another bunch of people, those who are getting a little bit more overweight. So they have moderate, mild obesity-related diabetes. And then as usual, as you get older, your chances of getting diabetes is higher. So you get this MARD, that is mild age-related diabetes. So it actually depends on your geographical position. And if you're in Japan, I think you would have more SIDD. If you're in India, you probably have more SIRD. So we need to understand these different subtypes of diabetes type 2 because each subtype has got a different predilection for certain complications. So if we are talking about CKD, as you can see, the incidence of CKD stage 3 or the progression to end-stage kidney disease is highest in people who are insulin resistant. So it's the SIRD subtype that predisposes people to getting CKD, right? And how soon? So the question is, how soon? So this data, which actually comes from this kind of same analysis where they have put the patients under the subtypes, you can see that in patients who are SIRD, that means the insulin-resistant type of type 2 diabetes, they are the ones who are at the highest risk of progressing to developing worsening nephropathy and albuminuria in the first 5 years of diagnosis. Now, let me be very frank with you. All of us specialists, we don't see patients with 5 years of diagnosis of diabetes coming. Most of the patients who are within 5 years of diabetes diagnosis are in primary care. So we will miss this opportunity, this very early opportunity to do something in the first 5 years of diagnosis. Because if you miss that 5 years, you can see that their risk is already the highest to get CKD. The next thing is I want to show you, and this is very important because, you know, this is how somebody's lifetime progression living with diabetes is going to look like. And as you can see, as you get diabetes, as you live longer with diabetes, you're more likely to get cardiovascular disease. And at the same time, you're more likely to develop diabetes complications. And what you can see from here is the minute you have got CKD setting in, it amplifies or it increases your cardiovascular risk substantially. And it actually shortens your time for getting a cardiovascular event. So this illustration highlights to us that the presence of CKD at any stage increases your CV risk. So we can say that CKD detection early is like a CV risk amplifier. And if you have more advanced CKD, it is more likely that your CV risk is going to be higher. And not only that, if you have CKD at any point in time, it is going to make your chance of getting a CV event even sooner. So picking up CKD is like telling us, you're not really going to wait until your patients get dialysis, you know. Your patients are more likely to die before they get dialysis if they have CKD. So over here, as you can see now, detecting albuminuria and monitoring the kidney function, both independently, will predict more cardiovascular events, more cardiovascular death, as well as more renal events. So this is the importance of looking for albuminuria and kidney function. And as you can see over here, the minute your GFR begins to decline, your chances of getting hospitalized for heart failure will also gradually increase. So it's not only getting CV events or renal events, it's also hospitalization for heart failure. And so the importance, therefore, for us talking to all of you who are the real, you know, I feel that you are the real foundation for looking after the patients in the primary care. This is the importance of CKD screening. Now, let me tell you very frankly, when we came up with the suggestions for this global primary care physician guideline implementation, we told everybody we have to get this message across the primary care. And that is because, as you can see, the burden of CKD is in stage 1 and 2. And we cannot be waiting to get stage 3 before we say we want to take action. So who are seeing the patients in stage 1 and 2? It's all primary care doctors. The patient is only going to see the nephrologist or a specialist when the GFR is somewhere near stage 3B, so it's like 45 and below. Then only the nephrologist or the other specialists are going to come in. So when they are all at stage 1 and 2, they are all with you. And this is the opportunity for you to make that very important decision to choose the correct therapies to prevent them getting CKD, prevent them getting heart failure, instead of ending up in trouble. So who are the ones you need to screen? Anybody who's got cardiovascular disease, anybody who has got diabetes, anybody who's got hypertension, because you can see that the prevalence of CKD in these group of patients is pretty high. So this is the reason why you need to screen all your patients with hypertension, coronary artery disease, as well as diabetes for CKD. And all these patients are with you. They haven't got trouble yet. So what is your action plan? So your action plan should be picking them up before trouble starts. Now, this slide was shown by Dr. Coco, and I like it very much because I tell you why. Our cutoffs for picking up CKD is too high. Over here, as you can see, the risk for cardiovascular disease starts at a very low albuminuria, in the presence of a normal GFR. So the risk goes up as low as 10 milligrams per gram. It's very, very low. But as you had seen just now earlier, shown by Dr. Coco very elegantly in his presentation, the cutoff is 30. Now you cannot wait until it goes to 30. 30 means it's already trouble. And we are talking about a cutoff of 60 for the GFR. Let me tell you, when your GFR is already 60 or below, half your kidney function is finished. It's gone. Why you want to wait until half the kidney function is gone? So, guys, come on. We're not going to wait for the fellow to come and see us, These patients are all with you. You are the people who have to act first. Don't wait for us to tell you what to do. These patients are all with you. And I tell you, you must do this. You see why? Because when you measure albuminuria, so albuminuria is what? Your glomerulus is filtering the filtrate. But if the albumin is escaping, it means that the filter is damaged. So what you're looking for when you look for albuminuria is a marker of the damage in the nephron. And when you're looking for the measure of the kidney function, you're just measuring the GFR. That is the function. But when you're looking for albuminuria, it is to look for damage. So this has to be checked at least once a year. So this is what you need to do. And as very nicely pointed out by Dr. Coco, you cannot just simply measure the EFR. The eGFR is not enough. You must also look at the albuminuria because you may miss early CKD if you just look at the GFR. And I saw some patients yesterday looking through their profiles. I think the measurement of UACR over here is a bit less. So we hope, and I think, in collaboration with SML Healthcare, we are trying to encourage you to do more screening for UACR because you guys are doing the eGFR, but you're not doing enough monitoring or screening the UACR, right? So patients who have got any degree of albuminuria, it's bad news. Now, when you're testing for the UACR, please make sure, because it's a spot urine, it's a spot urine sample. Please make sure they don't have a toothache, they are not having a fever, they're not having some, muscle pain, body pain, or they don't, in the morning they have not washed their car, or they have gone running around the lake. Then, of course, if you test, albumin will be there. So tell them to just be pretty normal and give you a sample. Because this is one of the caveats that you must advise the patient before you do the collection of the sample. Now, this is to show you, again, where we are missing it. So patients who are very early in CKD, we sometimes miss up to 50% of patients who have a normal GFR if you don't check the UACR. So up to 50% of patients with CKD have normal GFR, but if you don't check for the UACR, you will miss them. So let me tell you, that is a huge number because this is a US database. It's a huge number, right? So now the next thing, what we need to monitor, and I think this is very relevant to all of you because you are the ones who see your patients from the time they get diabetes and for the next few years that they are with you, that you are treating them. So it's important also not only to just measure, the UACR and the GFR at a certain time point, and then here's where we get carried away. We say that you must recheck the thing after 3 months to confirm. Not necessary. Because what you should be monitoring, and this is what all the nephrologists tell you to do, and this is what they see, is looking at the slope of the GFR decline. So what I mean by that is this. Now, patients are at accelerated risk of CKD decline if they are already in stage 3. When you are in stage 3, the slope is very down. So this group of people need to be treated urgently, but we don't want to wait until we see them there. So who are the patients that you are going to see? You are going to see those who are actually the ones with the hyperfiltrating kidney. I don't know whether there are any pathologists over here, but when we go to medical college, they will tell you that the first stage of diabetic kidney disease is glomerular hyperfiltration. I still remember from my baby Robbins, we read over there, it's like that. And then we have forgotten, when I did medicine 40 years ago, in Manipal, it didn't matter to us at that time because we never had SGLT2 inhibitors. But now we know. If you have glomerular hyperfiltration, which is defined by EGFR that is 2 times the upper limit of the standard deviation, 2 times the upper limit of the standard deviation. So it works out to be about 120 to 125 mils per minute. If it is more than that, your kidneys are hyperfiltrating. That is bad news. And I tell you why, because it means that the pressure in your kidney is very high, And that is the one, the hemodynamic changes, the shear force, and all these kind of things is actually going to make the inflammation that is going on in your glomerulus get worse and destroy your glomerulus. So these are the people you need to look out for, those who are hyperfiltrating. The next thing is, and this is very interesting because most of the data about rapid decline of GFR actually comes from Japan. And the Japanese define a rapid decliner as somebody who has an annualized rate of decline of more than 3 mils per year. So this is where I say, you don't need to actually repeat the test. You people are seeing all your patients in your clinic, right? Today, say you get somebody, his GFR is 78. Now say this same person, 3 years ago, the GFR was 98. Are you going to wait to repeat it again? No. You already know 20 mils has dropped in 3 years. That means it is average more than 6 mils per year. More than 6 mils per year means he falls into this category of fast decliner. So don't wait to check again. No need to check because you are keeping his record. You know the slope is already getting very fast going down. Don't wait anymore. These kind of people, you have to tell them, look here, maybe your diabetes is well controlled, but your kidneys are going down. If you are not on an SGLT2 inhibitor, you have to be put on one. Because we don't want to wait another few more years for your GFR somehow to go down below 60. So let me tell you, who is going to see this patient? It's not me. It's not Dr. Coco. It's you guys. It's you guys. So please ask your patients when they come, or if you have it in your record, you can document there. This fellow's annualized rate of decline is more than 3 mils per year. You got it. Start SGLT2 inhibitor early. Oh, sorry. So therefore, we will move on to telling you what does this slope of decline actually matter. It actually means a lot to your survival. So when you look at somebody's GFR who's declining too fast, you are probably not going to survive very long. So it's not only your kidneys not going to survive, you're also not going to survive. So please take action quickly and monitor the slope, right? So start SGLT2 inhibitors early because this is your opportunity to stop CKD once you find it. You can stop the CKD once you find it. And as you can see, from the point of risk factor recognition to screening to diagnosis and management, it is all the primary care physician's responsibility. I won't say it's your work, it's your responsibility Because when things get further complicated and there's progression, then only you should refer. So we are not going to see all these patients, honestly. We're not going to see them until they are here. You can see the purple comes very late down the line. So that's why I say you are the most important people for us to engage with. Because this decision is to be made by you. And if you make this decision, you will never go wrong. And I tell you why. If say now today you have 100 new patients getting type 2 diabetes, the majority of them are going to be having the features of metabolic syndrome. And now you know, the more components of the features of metabolic syndrome that you have, not only are you going to get CKD, you're also going to get fatty liver. So fatty liver is going to be our next project. Am I right, Dr. Amiat? Dr. Amiat is going to head our next project, and that is on how we can get you involved in looking for fatty liver as well. So you can see that if you have 100 new patients getting type 2 diabetes, 90% of them are overweight or obese. And a large majority of them will have the cardiometabolic risk factors, all of those things that you see. And therefore, ladies and gentlemen, this was the algorithm that I made some 10 years ago, which I think still holds good and makes sense today. And this is, if you have a patient who has got type 2 diabetes, you have started him on metformin, and his A1C is above 6.5, then you have to ask yourself, is this patient having the features of insulin resistance syndrome, which you will see all these features of the cardiometabolic risk factors. And you know that these are the patients who have got a higher risk of getting fatty liver and nephropathy. So for these patients, once you have failed on metformin, or if the A1C is too high to start with, maybe if your A1C is 7.5 or 8%, at the beginning, you want to use the combination therapy of metformin with an SGLT2 inhibitor. Later on, a better thing to use is pioglitazone, because these patients are all very insulin resistant. And therefore, the next one to follow is the first injectable will be a GLP-1. So here we are trying to follow the pathophysiology behind the development of the type 2 diabetes. And we are using targeted therapies to address the underlying pathophysiology. The worst possible thing you could do for this patient is give him a sulfonylurea. Now, on the other hand, if you have got patients who are this beta cell deficient phenotype, where would you find these patients? You will find them in Japan, Korea, and Taiwan, where genetically they have been predisposed to getting diabetes because of beta cell deficiency or beta cell dysfunction. And that is why in Japan, the #1 market leader for the oral diabetes therapy is DPP-4 inhibitor, in Japan. So if these people in Japan develop cardiometabolic risk factors, such as CKD or things like that, or heart failure, then they will add an SGLT2 inhibitor. But because their basic pathophysiology is insulin deficiency, it's associated with low insulin secretion, then the first injectable in this group of patients would be basal insulin. So this is how my thinking was about 10 years ago, how, I will tell my friends and my colleagues out there, when I see the patient, I refer back to my GP colleague. I tell them this is that's going on in my mind. And this is how you should probably take the approach so that the therapies that you choose for your patients will last long. If you choose the wrong therapies, then you will end up with unnecessary doing things, starting insulin too early. You're going to put a sulfonylurea on either side. You're going to kill the beta cell function even faster. You're going to make the person who's already got insulin resistance and metabolic obesity, make him even fatter, because he has got very functional, highly functional beta cells. You give somebody who's got metabolic syndrome a sulfonylurea, the poor fella is going to be hungry all the time. He cannot lose weight. He will be eating. And then later on, when his beta cell function has gone, you tell him, put him on insulin. Oh, goodness. So You are the most important people to make the decision, when it is very early on. So as you can see, the bulk of your patients will be those who are insulin resistant. So it should be metformin with SGLT2. And if there's no issues, they're not very elderly, they don't have heart failure, you could very well use a small dose of pioglitazone. It will work very well. And if it still does not give you the effect, then of course, we would prefer GLP-1. So let me tell you also the other important thing is why you must start the SGLT2 inhibitor as early as possible is because you need good kidneys. You need good kidney function for the SGLT2 inhibitor to work. But not only that, you will get better renal protection when you start your SGLT2 inhibitor early. Because if you were to start it when it's too late, say when you start it when it's already CKD stage 3, you can see that the benefit is already reduced. So it's not only the glucose lowering benefit that you want to get with good kidney function, but it is also to protect the kidneys from going down. So the sooner you start when the kidneys are functioning well, you actually protect the kidneys from worsening CKD. Now I want to tell you the third part of it is, what is this guideline-directed medical therapy? So it's pretty simple. And we know now that there are 4 pillars of preventing CKD in patients with type 2 diabetes. And let's take you now through how these therapies actually work hand in hand with each other. So when you put your patient with diabetic kidney disease on a rest blocker and control the blood pressure, you can see that you are trying to prevent that slope, the deep slope. You're trying to flatten it out. When you put in an SGLT2 inhibitor, you further flatten it out. And later on, if there is still residual proteinuria, despite being on a rest blocker, as well as good BP control, as well as putting an SGLT2 inhibitor, then that's when perhaps you want to use a mineralocorticoid receptor antagonist. And adding on all these 3 will further push the slope away, so you don't end up with end-stage kidney disease too soon. That is the reason why we have to follow this kind of adding on one after the other the agents. So first to start off with is the most important, and that is to tell your patient to stop smoking. They have to, maintain a healthy lifestyle, and they also have to exercise and manage their weight. Then later on, as you can see, the first line drug therapy for anybody with CKD is an SGLT2 inhibitor with metformin. Because these two, in combination, actually, the effect is better. Now, if for some reason you are unable to control the blood glucose and you need further addition of anti-diabetic treatment, or you need to intensify diabetes treatment, then putting a GLP-1 receptor agonist makes sense. And this not only just lowering down the HbA1c, but you will also get protection of the kidneys even further. Because in the flow study using semaglutide, what you can see is on the outcome of the primary outcome in the renal parameters, you can decrease the primary outcome by 24%. And if that person still has a lot of proteinuria, despite you giving him metformin, giving the person a SGLT2 inhibitor, or even putting a GLP-1 receptor agonist. And when I asked this question to Peter Rossing, who is from the Steno Diabetes Institute, I know Peter Rossing for more than 15 years because we have done a lot of clinical trials with Novo Nordisk. And I asked him, what are you doing there in Denmark? And they say that in Denmark, they usually start metformin, SGLT2 inhibitor, and then they will use GLP-1. So for them, the next step ahead is to use a non-steroidal MRA if there is still persistent proteinuria. So this is the place where you would use Finrinone, which is available as Firialta in Malaysia. It's available as Carendia in Europe. So here's where you would use Firialta or Finrinone. And you can further see that the impact on the primary outcome in the renal parameters is another decrease of about, if I'm not mistaken, it is about 14 or 16%. So this is the stepwise approach of how we should use our therapies, not only in treating the diabetes, but also in preserving the decline of renal function. There is also another point that we need to do here, and that is to control the blood pressure well. And sometimes we are told we should start a rest blocker. So be it an ACE inhibitor or be it an ARB, it's okay. But when you need additional blood pressure control, and the target should be, you must bring down the blood pressure to below a systolic of 130 millimeters of mercury at home. We have to make sure that the home blood pressure, self-monitoring, must be less than 130 systolic, right? You will probably have to add a calcium channel blocker on top of your rest blockade. And the data that we have to rely on is the ACCOMPLISH study. Now, this study was done very long time ago. What they did was patients who had hypertension were randomized to either getting rest blocker with diuretic or rest blocker with CCB. That means they were getting an ACE inhibitor, actually, bezanepril. And they were followed up over a period of 5 years. And what they found out was, for the same blood pressure lowering, whether you use rest blocker with diuretic or whether you use rest blocker with CCB, for same blood pressure lowering, you get additional 25% reduction in CV events. That is myocardial infarction and stroke, But when you look from the renal data, you also get better renal outcomes by combining calcium channel blocker with a rest blocker. So for us, it makes more sense to add a CCB rather than adding a diuretic, because it gives you better, not only cardiovascular, but also renal outcomes. So here's where this is very important for you, because we are telling you now, don't wait for the patient to come and see us, then only you want to start an SGLT2 inhibitor. You have to start. So when you are starting and you see your patient's HbA1c is good, say it might be 6.5%, but he's taking an SU, he's taking metformin, he's taking a DPP4 inhibitor. What I will do, I will take out the sulfonylurea slowly. I'll half the dose. If he's on basal bolus, you try to decrease the total daily dose of insulin. You first attack the prandial insulin, try to decrease it by about 20% or 30% of the total daily dose, and then you initiate your SGLT2 inhibitor. But you must be careful. If your patient's GFR is below 30, there is no effect on the HbA1c lowering. So the glucose lowering efficacy of SGLT2 inhibitor is dependent on the GFR. But the renal protective, the hemodynamic effects, the weight benefit is independent of the GFR. So if your patient's GFR is above 60, you will have to reduce the dose of the insulin, you will have to reduce the dose of the sulfonylurea, and then put in your SGLT2 inhibitor. Then you have to assess volume status. So if the patient is very hypovolemic, or the patient has got hyponatremia, you have to correct that first. And you do that by trying to reduce the loop diuretics, and then you initiate the SGLT2 inhibitor. And if that patient's blood pressure is well controlled, 120 by 80, say he's on a full dose of telmisartan, 80 milligrams, or he's taking 10 milligrams of amlodipine, what you could do is you could sacrifice the amlodipine a little bit. Because you must remember, if somebody is like, say, 70 years old and his systolic blood pressure is 120, it is actually much lower. Because you all know, as you start aging, your arteries become stiffened. So when you are measuring the blood pressure non-invasively, what you're reading that you get is actually higher than what is the true blood pressure. Because if you were to measure his blood pressure invasively, it might be 100, systolic. So be very careful. You got an older person, systolic 120 or something like that, please sacrifice the CCB or sacrifice the diuretic and then put your SGLT2 inhibitor. So that is why those days, when we used to measure, tell our medical students, you measure the pulse, you see what is the pulse. You also will see whether the radial artery is thickened. So if it feels like a shoelace, like your shoelace, then you know it's thickened. And these kind of people, if you get a systolic blood pressure measurement, which is non-invasive, 120, you must remember it must be actually lower. Because if you just add on the SGLT2 inhibitor, he will become giddy. So you need to make adjustments. And then, of course, when you are starting the SGLT2 inhibitor, keep all the other therapies that are useful, such as ACE inhibitor and the ARB. And then, of course, the diuretics, if you can sacrifice your diuretics, as well as the CCB, but don't sacrifice the ARB or the ACE inhibitor, right? Now, what are we aiming to reach when we are monitoring the UACR? Now, let me tell you, the UACR is the fastest marker that will tell you that the patient has responded to the SGLT2 inhibitor. Because if you wait to monitor the GFR, it takes time sometimes to see that it becomes stable, or sometimes it might actually go up. And we see this trend of going up if the eGFR is not too low. So if you start when the eGFR is around 50, along the way, it might actually pick up a little bit. And if you start at an eGFR that is very high, say 135, it actually normalizes the eGFR. But the first thing that you will be able to show your patient that the therapy is actually working is the UACR. So this UACR, what you want to show is that you have a reduction of at least 30% because that predicts a better outcome. It has prognostic value. So the reduction of albuminuria not only has got good effects for renal outcomes, it also has got benefits for CV outcomes. So renal outcomes, of course, it will protect your kidneys. So let me show you a real patient of mine. This is a 55-year-old type 2 diabetes patient who's a lorry driver. He's also got hypertension, dyslipidemia, and he smokes. And when he came to me, that was his blood pressure medication. He's overweight. His blood pressure is 180 by 100. When we look at his HbA1c, it's 9% on human insulin, metformin, and vildagliptin. His LDL cholesterol is 2.1, and he's on a statin, and his eGFR at that time was 36. So he's CKD, stage 3B at least. And when he just came, he came with the urine dipstick test. It shows a proteinuria of 3+. So in this kind of patient, what we have to do is you have to now stratify his risk. What are his risk factors in terms of diabetes, hypertension, and the lifestyle? And then you have to focus on each one of it. So he has got proteinuria, we need to do something. So for the proteinuria, the next step is to see the UACR. For the blood pressure, cannot, systolic 180. It has to be 130. And of course, he's obese, smoking, you have to attack all those things as well. Then when we measured his UACR, you will see something very scary. So this is in milligrams per millimole. We use that in Malaysia. But if you translate it to milligrams per gram, this thing is about 30,000. Very high. So the treatment aim is to prevent his kidney function from going down and also to decrease his cardiovascular risk. So we added on amlodipine and we gave him an ARB. And we also continued his atorvastatin. We put him on dapagliflozin 10 and we intensified the insulin and continued his metformin. And you can see when you put him on the KidneyGo guidelines heat map, he's already sitting in the red zone. So anybody in the red zone, you must treat them very aggressively. So this is how we monitored him over 1 year. And you can see how quickly this multifactorial or this multi-targeted approach of getting his blood pressure down, putting an SGLT2 inhibitor, controlling his diabetes, you can make the UACR almost disappear. From baseline, you have got it down to almost 99%. We are supposed to achieve 30%. Right? So the more you can reduce the albuminuria, the bigger is going to be the benefit. So you can use UACR as a measure of the response to the treatment. And this is very encouraging for your patient. because your patient can see, wow, I got so much of protein coming out, or rather, when I pass urine into the toilet, can see so much of bubbles. Now it's going. But you can show the patient in a very, objective way, how much the protein has actually decreased. So the UACR is the fastest to decline, the UACR. The EGFR, as you can see, it tends to remain stable. Initially, you'll see a dip, but later on, even that dip that you see initially is supposed to be a good prognostic indicator. But later on, what you will see is that there is stabilization of his renal function. It is not declining anymore. So we are now going to tell you in just the next 5 minutes, what is the golden time to start the SGLT2 inhibitor. So whole trouble starts with this. There's too much fluid in a diabetic patient who is hypertensive, and he's also got dyslipidemia. There's a lot of water retention. But those days, when we are treating patients with type 2 diabetes and obesity, we are just fixated on treating individual components of the cardiovascular risk. So we are focusing on the lipids, we are focusing on the glucose, we are focusing on the blood pressure, and we are focusing on the thrombotic tendency. So you probably want to give him aspirin or something like that. And then you're trying to prevent accelerated atherogenosis to slow down his event rate, getting a myocardial infarction or stroke. Now the thinking is a bit different. The thinking now is there are different insights. And there are a few things that we need to handle, one of which is hyperinsulinemia. This hyperinsulinemia is the culprit, actually, that kind of potentiates water retention. Now, there's something else called upregulation of the renal SGLT2 receptors, which also happens in somebody who's diabetic and obese. Not only that, I've mentioned it to you before that the first stage of diabetic nephropathy is glomerular hyperfiltration. And you also have got increased salt intake in most of these patients. And you have also got these tubular glomerular feedback mechanisms, which don't really work at that point. So what we need to do is you have to give them something to tackle this upregulation of the SGLT2 inhibitor so that you will address the volume status, you will address the hemodynamic and the glomerular stress that is going on in your kidneys. And by this is how you are going to prevent incident or progression of CKD and heart failure. So you can see now, our thinking has to change, because the old way of targeting all these risk factors is not really working. So this is what's happening now. In somebody who has got normal kidneys, that's what your kidneys look like with a GFR more than 90. But in the first stage of diabetic nephropathy, you know that the patient has got glomerular hyperfiltration. So when it's happening there, your nephrons are overworking. And when the damage begins to set in, that's when there is already going to be scarring of your kidney. And whatever remaining nephrons are overworking. So when you are down to 60 on your GFR, you have already lost half of your kidneys, And then now when it goes down even further, when you go to CKD stage 4, that's when you see your kidneys are more than half gone. And whatever remaining nephrons are being, tortured. So to prevent this, you need to start very early. Now, whatever we see, all these effects, improved glycemic control, improved insulin sensitivity, the weight loss, the blood pressure going down, all these things are actually the indirect effects of SGLT2 inhibitors. The direct effects of the SGLT2 inhibitors are actually on the hemodynamics. It prevents the glomerular hyperfiltration. It also prevents the glomerular and the tubulointerstitial injury. And by doing so, it also helps to decrease the oxidative stress. So this is the beauty about, see, ladies and gentlemen, you don't worry. After this, please contact Dr. Kain, or you can contact Dr. Amiat. You can get my slides. You don't have to worry about this one. I will give you my material. Because I feel there's no point in coming here and you are unable to follow this, I will give you my slides, no problem. No? So this is what I mean by the silent period is the golden opportunity for you to start the SGLT2 inhibitor. Because when you develop type 2 diabetes, the onset is over there. As you can see in the first 3 years, your glomerular filtration rate is going up. This is the hyperfiltration. And as soon as that happens, then you will start getting proteinuria because you're going to get damage of your glomerular filtration membrane. And this is a silent period when the appearance of albuminuria heralds the onset of diabetic glomerular sclerosis. Sclerosis means the fibrous tissue is already setting in. And over this period of time, the clock is actually ticking. So you are not going to wait until the GFR is dipping below 90, below 60, and going down to 30 when you will have overt diabetic nephropathy. You should be starting that SGLT2 inhibitor during the silent period. The earlier, the better. And I have already shown you in the first 5 years, this is the most important, crucial time, not to be missed. Because if you you waste 5 years, you waste 5 years, the damage has already started. So I hope you all can appreciate why I value the presence of all you people coming here today, you know. You are the most important people to make this change. And this is the most important role for you to play, that you can save your patient's kidneys from going down. So the take-home messages I want to tell you is CKD is very common, and the burden of CKD is not with the nephrologist. It's not with us, it's with you. The next thing is, of course, the early screening of CKD by checking the UACR as well as monitoring the eGFR and its slope is highly important to prevent progression of CKD as well as preventing cardiovascular events. And those patients who have got cardiometabolic risk factors, they are the ones, that means type 2 diabetes, obesity, insulin resistance, hypertension, dyslipidemia. These are the patients are the ones who are going to benefit the most from starting SGLT2 inhibitors very early. And last but not least, I have shown you that the silent period is the most important time for you to take action. Because once they come to us, the period is not silent anymore. The kidneys are crying. So with that, I thank all of you for your attention. And later on, if there are questions, we will be very happy to answer. But I'm sure you can later contact Dr. Kain and Dr. Amiat to obtain my presentation slides. Thank you very much.
Thank you, Dr. Radhakrishna Sothiratnam, for sharing your valuable insight with us. Season 4 ရယနေ့ဆွေးနွေးပွဲရဲ့အဓိကခေါင်းစဉ်ဖြင့် Associate Professor Dr. Vimaljit Kaur Sangat Singh, Consultant Pediatrician, Padana University, Malaysia မှထပ်ဆောင်ပြောကြားပေးသွားမယ် Vaccination in Primary Care, Best Practice for Immunization in Children အကြောင်းဟောပြောခြင်းပဲဖြစ်ပါတယ်။ Now, it's my pleasure to invite Associate Professor Dr. Vimaljit Kaur Sangat Singh to deliver the presentation.
I'm Dr. Vimal from Malaysia. I'm a retired pediatrician. So currently I'm teaching in a university, Padana University. I like to do a lot of teaching. So this is my slides. Just primary immunization in children, very, very important facts. And it's quite useful. Okay, very simple to understand. Okay, so what are our learning objectives to know the importance of immunization? And to immunize very early in life, that is preferably from birth, to be aware of complications, preventable diseases if not vaccinated, and very importantly, to follow the schedule, okay? So why do we have to immunize a child, okay? So it's very crucial in preventing serious diseases. It saves millions of lives. And how do vaccines work? They reduce the risk of the disease by the natural defenses to build protection and enhancing your immune system. Okay. So it's very interesting. This is Edward Jenner, the first immunization by this physician by the name of Edward Jenner in 1796. He inoculated a boy. His name was Philip. So he noticed that the milkmaids, they had cowpox, but they didn't get smallpox. So there was an outbreak of smallpox at that time. So he got that lady by the name of Sarah, who had cowpox in her hand. He took the fluid of the cowpox and he inoculated Philip's. Okay, he made some cuts there and he inoculated Philip's. The Philip wasn't well for a week, but after that, he was fine. So what he decided to do is he took the lesions from the smallpox and he inoculated Philip's again. And Philip didn't get smallpox. So that's how he invented the smallpox vaccine in 1796. Yeah? So these are the general principles when you want to immunize a child. Okay, vaccines, when you give live and inactivated, they can be given simultaneously. So if you give oral polio vaccine, you can even give any, oral polio is live. You can even give a inactivated vaccine together. So you don't have to worry. So sometimes you can give multiple vaccines, but at different sites. Okay. So your oral vaccines, examples of oral vaccines is what? Rotavirus and polio drops. And intradermal will be for your BCG, for your tuberculosis. And if you want to give subcutaneously, it's mainly for live vaccines. Okay, so why do they give it subcutaneously is because the absorption is slowly. Okay, and if you want to give intramuscular, that is most of the vaccines are intramuscular. Okay, so where do you give the vaccine intramuscularly? You give it at the deltoid as well as you give it at the thigh. Okay, sorry. Okay, so at the thigh, we give it at the, this part of the thigh. Can you see here at the vastus lateralis? And for the deltoid, we give it at the arm. Okay, and this is the site where the acromion process is here. And your deltoid, we about 2 to 3 finger breadths. That's the site which we give the vaccine. Okay. And for the vastus lateralis, we give it at the thigh. So with area, we divide the thigh into 3 parts. So can you see this part here? The greater trochanter, we give the vaccine here. So it is the junction of the middle and upper thirds of the vastus lateralis. So if you want to give intramuscularly, you have to give it at 90 degrees. But if you want to give subcutaneously, you can give at 45 degrees. So you can use the same sites, but at different angles. If you want to give subcutaneous, it's mainly for live vaccines. But if you want to give intramuscularly, it's mainly for the kill vaccines. So the absolute contraindication for vaccine is what? Anaphylaxis. That means you have severe life-threatening reactions. And that means you gave this vaccine and the patient developed anaphylaxis, you cannot give the vaccine again. So that's the absolute contraindication. So what is anaphylaxis? There's some swelling in the throat, the tongue, there's difficulty in breathing, okay, there's hoarseness of voice, and then there's coughing, feeling very tired, he feeling faint, and then he develops rashes, urticaria, very itchy rash, and then he may become blue, gray, and he become pale. Okay, so this one is just easier to understand. You can see that can affect the airway. Patient has shortness of breath, difficulty in breathing, unable to swallow. His skin, he get a lot of hives. Hives is urticaria and very itchy. And suddenly he will have cramps and diarrhea, nausea and vomiting, and a drop in blood pressure, increased heart rate, weak pulse and faint. So if you develop these symptoms, that means you cannot give this vaccine to this child. Okay? So can you postpone Yes, sometimes during acute illness, not necessarily urgent, you have to give the vaccine. So you have high fever, you can postpone for a week and then you can give the vaccine. So if you have minor infection like slight fever, it's not a contraindication. So absolute contraindication for live vaccine if you're immunocompromised. That means you're on irradiation, you have on chemotherapy, you have leukemia, you have post-transplant, the primary immunodeficiency syndromes. These are usually we don't give the vaccine. Okay. And during pregnancy, can you give the vaccine? Usually live vaccine you cannot give. Okay. So unless there is a serious condition like polio or yellow fever, the risk outweighs the benefits. I mean, the risk is very high, so you may have to give the vaccine. So if you have to give live vaccines, you have 2 live vaccines like oral polio vaccine, and you want to give another live vaccine, you can give it together. But if you didn't give together, you have to wait for 4 weeks. Example, if you have done a tuberculin test, a MANTU test, it's a live vaccine, right? It's a live thing, right? BCG, right? So if you've done a MANTU test, you have to wait 4 weeks before you give your live vaccine like MMR. Okay, so if you want to give live vaccines, you give it together, no problem. But if you didn't give together, you have to wait for 4 weeks. Okay. So what do vaccines do? They actually protect the child from diseases. So we have like vaccines like tetanus. Nowadays, we don't see tetanus, right? But in certain parts of the world, like India and all that, sometimes when the baby is born, they put cow dung on the umbilical cord. So you're prone for the child to get tetanus. So if you don't vaccinate the mother, you don't vaccinate the child might develop tetanus. Okay. Measles also can cause a lot of brain damage. Now in America, because many people don't believe in vaccination and a lot of people migration, the foreigners go there, they spread measles. Okay. So, but these people, they don't believe in vaccination. Now there's an outbreak in measles. Okay. And can cause brain damage. Okay. Polio. So now we know that we have almost eradicated polio, right? Because of the oral polio vaccine. It's a very dreaded disease. You can have a lot of weakness and lifelong paralysis. Okay, whooping cough is another problem in small babies because the first vaccination for whooping cough will be at 2nd month. So what happens from birth until 2 months? The baby is not vaccinated. So nowadays, what we do is in the Malaysian government, now they are giving Tdap, that means to the mothers, so that babies are protected when they are born. Okay. So this is my mnemonic for live vaccines, Mr. Spy Bee. So sometimes people, when I teach people who go for exams, so they ask you, what are the live vaccines? Okay, so we have other addition as well. So Mr. Spy Bee is, Mr. is measles, mumps. R is rubella, rotavirus. S, smallpox. Nowadays, we don't have smallpox. P, polio. And Y, yellow fever. B, BCG. The other addition is takes chicken juice and durian. Okay, you all like durian? So this is my own mnemonic. Okay, so takes is typhoid is oral. Okay, oral typhoid is live vaccine. Shingles, we have the live as well as the kill. The live one is Zovestex. Okay, the one we don't have in Malaysia. I mean, nowadays we don't give in Malaysia, we give Shingrix. That is the kill version. But Zovestex, it was a live vaccine. Okay, chicken pox is a live vaccine. Influenza intranasal is live. Japanese encephalitis is live, and dengue. Okay, so these are the live viruses. Okay, live vaccines. They are live, but they are attenuated. It's not like so virulent. Okay, so these are the live vaccines. So Mr. Spy Bee takes chicken juice and durian. Okay. Okay, in Myanmar, I believe this is your immunization schedule for children. So correct me if I'm wrong. So BCG and hepatitis B is given at birth. Okay, that is, I think, standard, quite good. But you all give pentavalent. Pentavalent, we give hexavalent. So pentavalent consists of DPT, diphtheria, pertussis, tetanus, Haemophilus influenza, and hepatitis B. And your polio is oral, still oral. Okay, but we give killed. So we give IPV. So we have 6 vaccines in one. So we have hexa, but you all have penta plus you all give the polio oral. Okay, so and rotavirus, I think, I'm not sure whether you all give it the government or they have to buy it on their own. I'm not sure, but it is available. And pneumococcal is in your immunization schedule. Okay, it's very important. So it's there. And measles and rubella. But in Malaysia, we give mumps as well, MMR. Here, you all give mumps, measles and rubella alone. But we give mumps, measles, and rubella. And I think the secondary school children, you all give HPV as well for the human papilloma virus and tetanus toxoid. So this is your immunization schedule. At birth, up to 2 months, they give BCG, hepatitis B, DPT, HIP, and hepatitis B at 2nd, 4th, and 6th month, 18 months. OPV, 2nd, 4th, and 6th months. MR is measles and rubella at 9 and 18 months. Tetanus and diphtheria during pregnancy. I think they give at first contact and 4 weeks later, 2 doses to pregnant ladies. Pneumococcal vaccine at 2nd and 4th and 6th months. Japanese encephalitis at 9 months. Rotavirus at 2nd and 4th month. And for girls, the human papilloma virus. And also vitamin A is provided. So why do we give vitamin A? Because whenever you get measles, you can have depletion of vitamin A and can cause blindness. Okay. This is our immunization schedule in Malaysia. Okay. So we have BCG and hepatitis B at birth. And then we give hexa. We have DTaP. Why is it DTaP? Because our pertussis is acellular, but your pertussis is cellular. So what is the difference? Because acellular has lesser side effects. So we have acellular pertussis. IPV, we don't give oral polio vaccine. We give killed polio, and is inside hepatitis B and HIP at 2, 3, and 5, and booster at 18 months. Measles alone is given in East Malaysia, that is Sabah. So they get an additional dose in Sabah. But in West Malaysia, we give 2 doses only, MMR at 9 months and 12 months. So Sabah gets 3 doses, but West Malaysia gets 2 doses. Pneumococcal vaccine, we just also started. So we give at 4 months and 6 months. Previously was PCV 10, but now it's PCV 13, same like Myanmar. Okay, PCV 13. Huh? Okay, and booster at 15 months. And JE, we don't give in West Malaysia. We only give in Sarawak. That is East Malaysia. We give 9 months and 12 months, we give JE. Caused by mosquito, the Culex mosquito. And DT is given at 7 years old. HPV given at school children, 2 doses at 6 months apart. And tetanus toxoid is given at 15 years old. Okay? So this is just to elaborate. Okay, so you can see BCG, protection against tuberculosis. Hepatitis B against hepatitis B. DTaP, that means diphtheria, tetanus, acellular pertussis. IPV is the kill polio virus, hepatitis B, and Haemophilus influenza type B. Okay, and then we have pneumococcal vaccine against streptococcus pneumonia, very important. Okay, and JE is given here in this is Sarawak. Okay, this is Sabah. Okay, this is West Malaysia. This is East Malaysia. Okay, and measles only in Sabah, so they get extra 3 doses. And MMR gives measles, mumps, and rubella. Okay, and we give booster at 7 years old. And HPV, we give 2 doses. For human papilloma virus, we give 2 doses for 13-year-old. And tetanus is given at 15 years old. So if you follow your immunization schedule, you're protected against many diseases. Okay, these are the additional vaccines which we have. Okay, rotavirus, you must give before 6 months. Okay, so your first dose usually given by 6 weeks. Everything should be completed preferably by 6 months because the risk of rotavirus is very high for a small child. They can have a lot of diarrhea, vomiting. And pneumococcal, no more additional vaccine is part of the immunization schedule. Influenza, also important. After 6 months of age, you can give, and you give 2 doses. But after 8 years old, is 1 dose only, once a year only. But before 8 years old, is 2 doses. Meningococcal is not endemic in Malaysia, but sometimes when parents ask for, they are traveling a lot, we give them meningococcal vaccine. Hepatitis A, also we don't give routinely, but if the patients ask, we can give. And varicella for chickenpox after 1 year old. So what it means is, this is just a simple slide to tell you what it means. So BCG stands for Bacillus calmette-guerin, is for tuberculosis. DTaP means diphtheria, tetanus, and acellular pertussis. Okay. IPV is the inactivated poliovirus. HIP is Haemophilus influenza type B. MMR is mumps, measles, rubella. DT is diphtheria and tetanus. HPV is human papilloma virus. TT is tetanus. The optional vaccines now, pneumococcal is no more optional, but you start at 2 months above. Influenza, after 6 months, you can give. And rotavirus also between 6 weeks to 6 months. Okay. And hepatitis A after 10 months, and chickenpox after 1 year. Okay, so kill vaccines are very safe. The absolute contraindication is after the vaccine, sometimes you can have a lot of induration and very and severe reaction. That means next time you cannot give the dose already. Okay, so this is the only absolute contraindication for kill vaccine. Okay, so the following are not contraindications to vaccination. So people ask you, when can I give, when can I give? So you have a mild illness, no problem. You have asthma, eczema, a little bit of rash, you don't give at that area, you can give in another area. And if you're on antibiotics and just low dose steroids and inhaled steroids, usually no problem. If mother is breastfeeding, also is not contraindicated. And even if the child is breastfed, you still can give the oral polio vaccine. And even the baby has jaundice also, you can give the baby vaccine. If the baby is underweight or malnourished, also not a contraindication for vaccine. And if the baby, like supposing scheduled for vaccine at 2 months, but he comes at 6 months, can you give the vaccine? Yes, you just continue. That means if he didn't receive his primary immunization at 2 months, he come at 6 months, you start back like that. So it's considered that is at 2 months and you continue. You never restart the whole thing, no. You just, wherever age he comes, you just continue which vaccine he hasn't got, okay? And any stable neurological conditions also is not a contraindication, okay? And if there's a family history of convulsions, history of heart disease, congenital or acquired prematurity, there is no contraindication. So BCG, how is it given? Is given intradermal. Can you see that? So babies, when they are born, they give them intradermal BCG. And what does BCG protect you again? Does it protect you completely from pulmonary tuberculosis? No, the protection is only 0 to 80%, but it prevents you from getting meningitis and disseminated TB. Okay, so for you, your pulmonary tuberculosis is not 100% protection, but for meningitis and disseminated tuberculosis is useful. Okay, so this is very important also, BCG adenitis. So sometimes after BCG, I'm sure you would have come across, baby will come in with swelling at the axilla. So sometimes you have to see whether is it suppurative or non-suppurative. That means, is it indurated or is it like fluctuant? So if it is indurated, usually you don't need to worry. By 10 months, it will disappear. But if it is suppurative, that means got pus inside, you can put a needle and aspirate. Okay, but you cannot make an incision. If you make an incision, what happens? You develop a fistula. So don't make an incision. If you want to remove it, you have to excise. Okay, so sometimes some of them, they give some anti-TB treatment, INH or some erythromycins, but usually it's self-limiting. Okay, but if you have many babies with this, you have to notify that batch. You have to inform the place, the health place, that batch, many babies develop this BCG adenitis. Okay. Okay, so this is very interesting. I just want to spend some time on oral polio vaccine and IPV, the kill vaccine. So in places where you haven't immunized anybody, you start off with oral polio vaccines because that is mass immunization. But once there's no polio in that region, you can give the kill vaccine. That is the IPV. So in Malaysia, we don't give oral polio vaccine. We give the kill vaccine. But here, because many places not immunized, so they're still giving the oral polio vaccine. But once the community, everybody, and the surveillance doesn't show any polio, you can switch to kill vaccine. Okay. So a little bit on polio. So if you see what's the difference between how to remember Salk and Sabin. Salk got K there, right? So that is kill vaccine. That's the kill vaccine. K there. So there's a kill vaccine and it's injectable, right? And Sabin is the oral polio vaccine. So this is the inactivated form and this is the live. This is injected. This is given orally. This Salk was developed first. After that, they developed the oral. Okay, so this one got less side effect. But this one, what side effect can you have with oral polio vaccine? You can develop circulating derived vaccine polio virus. That means what happened is the oral polio vaccine, the live virus, the attenuated one, become mutant and is excreted, and that also can cause polio. So when does it cause polio? Is when many people not immunized. So in the community where the sanitation is poor, many people not immunized, they can get, okay? So the oral polio vaccine is very safe. It interrupts the person, but it's very good. Why? Because when you take the oral polio vaccine, it confers gut immunity as well. And also it confers humoral immunity. So it prevents the spread of polio, plus also it prevents the patient from getting polio. Okay, so very good. So that's why for mass immunization, oral polio vaccine is very, very good. But the risk is that oral polio may turn into a mutant strain and can spread to someone who was not immunized. Okay, so but it protects that person because there's gut immunity. So how is polio transmitted? It's actually fecal-oral route. It's the enterovirus. What other enterovirus do you know? Rotavirus, Coxsackie, polio, all are enteroviruses. It's fecal-oral. So it's when the child ingests that, so if you give the oral polio vaccine, his gut is sterilized. So he doesn't spread the virus to other people. But only fear is the thing might become mutant. Okay, but IPV, when you give, he just protects that person, but he doesn't prevent. Supposing he ingested the oral polio vaccine, that if he ingested the virus, he still can excrete in his gut because his gut is not protected. So that's why he can spread to other people. Okay. Okay. So the global efforts to immunize children with oral polio vaccine have reduced the wild polio a lot since 1990. In Myanmar, do you have cases of polio? Do you all have cases of polio? No more, right? Okay, so how is the immunization uptake here? Do many people come for the immunization? Is small babies when they are born, is it necessary for them to immunize? So, but you all haven't decided to change to IPV? Not yet, eh? So why? Because there are some areas where not immunized? Because once the community is fully immunized, you can change to IPV. Okay? Okay? So the vaccine is very safe and interrupts person-to-person spread of polio. However, on rare occasions, under-immunized population, live weakened virus contain OPV can mutate, and you call it the circulating vaccine-derived polio virus. Okay, so this is so now the global the plan is to eliminate the mutant form as well as the wild form. Okay. Okay, so the wild polio is the one which you're very worried about, right? So we want to eradicate that. So how do you actually reduce the mutant form is because they found out that type 2, because we have type 1, type 2, type 3 in the wild polio. Okay, so they found out that the type 2 is the one causing the mutant form. Okay, so what happens is, but the main cause of polio is type 1. So now they make vaccines without the type 2 strain. So that's what they're doing now. So you can reduce the incidence of the mutant, the circulating derived polio vaccine. This one, you can circulating vaccine derived polio virus. Yeah. Okay. Okay. So oral polio is given very cheap. So we have the three polio virus strains. Bivalent is type 1 and type, I told you type 2 is the one causing the circulating form, this one, okay? And body produces antibodies in the blood as well as the gut. So it's very good to give oral polio vaccine because it sterilizes your gut, plus it prevents you from, it also induces the humoral immunity. So it prevents person-to-person spread, okay? And the IPV is good. Once the community is all immunized, we can change to IPV. Okay. So hepatitis B. So in Malaysia, all babies born, we give hepatitis B vaccine. So including hepatitis positive mothers also, babies we give hepatitis B vaccine, plus we give immunoglobulin. Okay, immunoglobulin must be given by 12 hours, but preferably before 48 hours. Okay? So in Myanmar, you all have your own vaccine by SML. It's a recombinant vaccine, can be given both in children as well as adults. Okay. Whooping cough is also another problem because in the ward, we see a lot of babies coming with intractable cough, coughing with subconjunctival hemorrhage, become apneic because mother has pertussis and baby is not immunized. So this is the 100-day cough, very contagious, and baby may struggle and gag. So in Malaysia, we started the vaccinate the mothers. So at least the babies are protected. Okay. So we prefer acellular pertussis because lesser side effects. Okay, lesser encephalitis, lesser anaphylaxis, okay, less fever. So it's in our hexa, in our immunization. Okay. So this is our, just recently, our Minister of Health, he introduced the Tdap. So what's the difference between DTaP and Tdap? Okay, because when we give patients in primary immunization is diphtheria, tetanus, pertussis, is DTaP because it's full dose of the vaccine because you want to protect the children. But for the mothers, we're not protecting against diphtheria or so mainly it's for tetanus and a lower dose of pertussis. So it's known as Tdap because of a lower dose of the vaccine. So that's a difference. In small children, we give DTaP. But for mothers, we give Tdap. Okay, so we have a component of acellular pertussis so that baby gets some protection. Okay, by passive immunity, it will be passed to the baby. Okay, pneumococcal vaccine, very important because it prevents invasive disease as well as non-invasive diseases. Non-invasive is otitis media. Invasive is septicemia, meningitis, and pneumonias. So we have our pneumococcal vaccine. Myanmar also, from Prevena 10, now it is Prevena 13. So they have, in I think 2018, you all are giving PCV 13. So that's good. It protects you against many strains of the Streptococcus pneumoniae infection. Okay. Rotavirus, also important. But in Malaysia, we don't give it as a primary immunization. Parents have to buy. Okay, we have two types, Rotarix and Rotatec, and has to be given before 15 weeks of age, and they should get the first dose. And before 8 months, you should complete all the vaccination. So if you give Rotatec, it's 3 doses. If you give Rotarix, it's 2 doses. And what is the side effect you must look for? Once you give Rotarix, have you ever seen anybody with intersusception? So once you give the rotavirus vaccine, which is given orally, patient can develop intussusception, the telescoping of the intestine. So you must look out. What are the signs? Patient have severe abdominal pain, distension, and they pass current jelly stools, blood in the stools. So you must look out for intussusception. So that's one of the complications of rotavirus vaccine. Okay, and measles, very important, is already coming up again. So it's also known as rubeola. It's airborne. It's a viral infection. And before the rash come out, you can get Koplik spots. Koplik spots are small spots near the buccal mucosa, where when you see in the torchlight, you can see the Koplik spots. So this is the Koplik spots, white spots. Okay. And measles, they're very miserable. These babies are very miserable looking. They have a lot of catarrhal symptoms, watery eyes, face all red, okay, rashes everywhere. And after the child recovers, there's staining of the body. That means you know it is measles if you have staining. If you don't have staining, it's not measles. That means after they recover, you can see brownish stain over the body. So you know that is measles. So sometimes you need to remember what day of fever and what day of the rash come out. So we have a mnemonic. Very sick people need double treatment. So we need double tablet. So very is varicella. So on first day of fever, then you develop rash. After 1 day of fever, you develop rash. That is varicella, chickenpox. Very, what's that? Very, okay. Then after that is P is pox. No, very sick. Sick is scarlet fever. Second day of your fever, you develop rash is scarlet fever. Very sick people. P is pox. There's smallpox now, no more. So, okay. Very sick people must measles. Measles, after 4 days of fever, you get the rash. Must take is typhus. That means scrub typhus or what. You after the sun, you get the rash. Okay. After that, it is take a double tablet. Double is dengue. That is on the 6th day, and the 7th day is typhoid. So if you remember this mnemonic, you know roughly which day of the fever, then after that you develop the rash. So very sick people must take double tablet. So varicella, sick scarlet fever, people is pox, measles is fourth, very sick people must take typhus. Then after that it is dengue. After that is typhoid. Okay, so you must remember, so roughly you'll know which day of the fever and then the rash develop, you can know what is the problem. Okay? So complications of measles is quite a lot. You can have otitis media, you have diarrhea. The most important things you're worried about, the eyes can cause blindness. So we give vitamin A. Whenever you got measles, please give vitamin A to the child. Okay, so how much of vitamin A do we give? So if you have a child less than 6 months, you can give about 50,000 units daily for 2 days. If about 6 months to 11 months, you can give about 100,000 units daily for 2 days. And if you're above 1 year, it's 200,000 units daily for 2 days. But if you are deficient, another 24 hours apart, you can give another dose. Okay. Influenza, it prevents a seasonal flu. I think it's quite useful to take because we have the rainy season, and if you're traveling a lot, so it's good to take the influenza vaccine. Above 6 months to about 8 years old, you take 2 doses, but above 8 years old is 1 dose. Okay, and I think SML has its own supply of influenza vaccine. It's produced by in South Korea. So we have the quadrivalent vaccine covering both the influenza A as well as B. Okay. And we have the dengue. Is dengue a problem here? Dengue? So we have Dengvaxia and Qdenga, but we prefer to take Qdenga because Dengvaxia is also a live attenuated vaccine. I think in Myanmar, you all have Dengvaxia, but you have to check the status. These patients have to have dengue before, because if they don't have dengue, you cannot give this Dengvaxia. Okay, then we have the Qdenga. You don't have to check the status. And any child above 4 years old, you just need 2 doses. And it contains that 4 strains, the Deng 1, then 2, then 3, then 4. So you can take 2 doses, and they said it's quite effective. So we have Q dengue in Malaysia. Rabies, this is the last slide. Rabies, I think quite endemic in Myanmar. Okay, so about 150,000 people are bitten by animals, and most of it is by dogs. I think number of human rabies cases has been declining, but still a public health issue. Myanmar Dogs, I think, is actively working in collaborating with WHO. So SML has its own vaccine. So this is the rabies vaccine in Myanmar. So they have the pre and post exposure prophylaxis. Okay, so do you all treat rabies as well? Yeah, so it's quite common for you all. Okay, and so 3 vaccines solely distributed by SML is hepatitis B, influenza, and rabies. Okay, so with that, be wise, please immunize. Okay, so thank you.
Thank you very much, Associate Professor Dr. Vimaljit Kaur Sangat Singh, for your informative presentation. ခန်းနာစီစဉ်9ရာတက်ရောက်လာကြသောဧပရိသတ်များမှတည်လို့သမျှမေးမြန်းနိုင်သည့် question and answer အစီအစဉ်ပဲဖြစ်ပါတယ်။မိခွန်းများစတင်မေးမြန်းနိုင်ပါပြီရှင်။
Thank you very much. Thank you very much for all the speakers, for the eminent speakers. I'm so much appreciated for your talk. First of all, I would like to ask 2 questions to Dr. Radhakrishna and 1 question to Dr. Professor Kuku. Number 1 question is, who should avoid SGLT2 inhibitors? In other words, what are the contraindications for SGLT2 inhibitors? For example, type 1 diabetes mellitus, and what other else? Number two question is, you have mentioned that ACE inhibitors and ARBs are most suitable for hypertensive patients with diabetes. As compared to ACE inhibitors and ARBs, most of the doctors and patients most of the patients cannot tolerate ACE inhibitors because of dry irritating cough, and we prefer ARBs. And among the ARBs, losartan is less expensive and easily available. Which one do you prefer? I mean, which is the most appropriate ARBs, valsartan or candesartan or irbesartan or others? This is the second question.
Thank you for your questions, Professor Mala. I will be very quick to answer the first question, and I think this is very clear. Anybody with type 1 diabetes, SGLT2 inhibitors are not indicated at the moment. And this is only because you have to be very careful. Even in some patients with type 2 diabetes who are taking insulin, we have to make sure that if we are giving them SGLT2 inhibitors, they must not cut down the insulin dose. Because if you cut down your insulin dose and you take SGLT2 inhibitors, you are very likely to develop euglycemic DKA. There are no strict, or rather, how you would say, absolute contraindications for SGLT2 inhibitors, unless you have got some recurrent urinary or genitourinary infections that might be related to a structural problem with the urinary tract. So if you have somebody who has got urinary tract urethric strictures, or somebody who has undergone some pelvic surgery where there is obstruction of the urine outflow, then these patients are at risk of developing recurrent urinary tract infections or ascending pyelonephritis. So these kind of patients, you have to be a little bit cautious. Perhaps the benefits do not outweigh the risks. But otherwise, if we are talking about starting SGLT2 inhibitors in primary care, where in the first 5 years of diagnosis, most of these patients don't have any problems at all. So only these are the patients whom you need to be careful. There is advice for patients who are taking SGLT2 inhibitors. The risk of euglycemic DKA is enhanced if you were to cut down your daily carbohydrate intake by more than 40% of your total daily calories. So you should not allow your patient to take less than 40% of his total daily calories as carbohydrates, because this will predispose that patient to developing euglycemic DKA. So you have to advise your patient, don't be too much of the so-called Eskimo diet, where they cut down their carbohydrates too much. So there's some nice data coming out from Japan where they say that you must not go below 40% of your total daily caloric intake. It has to be carbohydrate. So we must tell, because some people, they want to lose weight. They are very, this one, they cut down the carbohydrate too much. And of course, you need to tell your patients regularly that if they are taking an SGLT2 inhibitor, the sick day advice. So whenever they are having diarrhea, vomiting, and they are having some very bad infection going on, they should temporarily stop the SGLT2 inhibitor until they have recovered. So it's very simple, and we usually don't have any issues putting SGLT2 inhibitors in our patients in primary care. The second question, I really appreciate you bringing it up, Prof. Mala, in that you see now in most of the developed Asian countries, so if you're talking about Korea, and I quote the Korean hypertension fact sheet, which you can very easily access. In Korea, the leading antihypertensive is ARB. And in Korea, if you look at the total prescriptions of ACE inhibitors throughout, I think, 2023, it's only 200,000 patients. Very few, whereas there are some 7 to 8 million Koreans taking ARBs. Now, that is precisely the reason that if you were to continue taking, or you want your patients to be persistent in taking their hypertension medications, the patients who are taking ARBs are least likely to stop. So it's very good for compliance. The next question you're asking is, which of these the ARBs are preferred? Now, seriously, and this was told to us by Bjorn Daloff. Bjorn Daloff, was the principal investigator of the renal study. And he himself, although they said losartan produced very good results in the renal study, but Bjorn Daloff admitted, he said, had the ARBs appeared before the ACE inhibitors, the ACE inhibitors would have never come onto the market because of its lousy, tolerability profile. Now, when you want to compare, which ARB is better, I think it is important for us to recognize that for blood pressure lowering, just for blood pressure lowering, if you were to give half maximal dose of the ARB, is enough. Likewise, with the ACE inhibitor, if you want to lower the blood pressure, half maximal dose is enough. But if you're talking about organ protection, then you have to hit the top dose. And this is because if you give an ARB at half maximal dose, you're probably only going to block about 60% of your AT1 receptors. If you give a maximal dose, not maximal, but the top recommended dose, so say you give 100 milligrams of losartan, you are able to block more than 90% of your AT1 receptors. So that is for organ protection. You talk about ACE inhibitors, it's a different way of explaining it. So ACE inhibitors, we know you have got tissue ACE and you have got vascular ACE. So vascular ACE inhibitors are like circulating in the circulation. They do not penetrate into the target organs. So the example of a circulating ACE inhibitor is quinalapril, which is made by Pfizer. So that does not penetrate into the tissue. Now, for you to give antihypertensive and ACE inhibitor to lower the blood pressure, Because even if you give the top dose, you don't lower the blood pressure too much. But half maximal dose is good enough. For organ protection with an ACE inhibitor like ramipril or perindopril, you have to hit the top dose. So ramipril, you have to give 10 milligrams. Perindopril, you have to give 8 milligrams, because at that dose, although you get a little bit of blood pressure lowering, the more important thing is you are achieving maximal tissue penetration into the target organ. So you are achieving maximal tissue penetration into the coronary arteries, into the brain, and into the kidneys for organ protection. So if you now ask, which of these are better? Okay, you compare the, if you compare the ARBs, losartan has a shorter half-life. If you compare the other extreme, olmesartan and telmisartan have a longer half-life. Now we know for sure losartan, even at 100 milligrams, towards the end of dosing, that means if you were to take it today and then you are waiting until the next day, towards the end of dosing, the last 3 or 4 hours, there's a little bit of loss of efficacy. But this is non-significant because if you're combining it with an amlodipine, then it's negated. But on the other hand, if you have somebody taking telmisartan or olmesartan, which is even longer acting, these patients, I use these kind of drugs for patients in whom you cannot be relying on them to take the tablet every time at the same hour. So who are they? They are pilots or they are air crew who have to travel across time zones. So if you take telmisartan, even if you miss the dose for 2 or 3 days, your blood pressure doesn't go up. It's like amlodipine. So I think there is very little to choose about organ protection or blood pressure lowering, but it depends on how you want to treat your patient individually. So I hope you have got the answers that you wanted.
Thank you. Thank you. Another question to Professor Kuku is you have mentioned about finerenone. It is too expensive and then not easily available here. So when should we prescribe finerenone to that patients with CKD?
Thank you, Ma. So at the moment, finerenone is available in Myanmar, but not by the registrar drugs. It's coming through the border. So we buy it with the 6,500 just per 10 mg. But next 2 months' time, I will be talking on the launching of the FDA registrar finerenone in Myanmar. It will be produced in Pilawa in locally, and it's 10 mg, maybe 2,000 just. And then 20 mg, maybe 25,000 just. It's very, very less amount for that. So we will be available in the October 12. So October 12, they will be launching by the CFAN company. And then this speaker will be me as well as the other one. So what things at the moment is, if you give a finerenone, there's a 3 approach. One approach is traditional approach. Traditional approach means at first, you need to put on the ACI or ERB with the maximum tolerated dose, and you combine with the SGLT2, wait for 3 months, and stay, if you are still going on, you put on the finerenone. This is started with the, if your eGFR is okay, the good drugs is 20 mg. If eGFR is less than 30, you go for 10 mg. This is the traditional approach. Another one is now accelerated approach. It's a rapidly the sequencing approach. Means if your patient has very high risk, they can go on all the 3 drugs, combination of the SGLT2 and then ACI and ARB and then finerenone. Within a month time, all the drugs should be put on. So this is another approach. So what we like at the moment, what they call is accelerated risk management approach. So you look at the one patient, if you are at low risk, go for traditional approach. Okay, if you are in a very high risk approach, go for record sequencing approach. So give 3 months after ACI and SGLT2 by the traditional approach is for the low and moderate risk. If you are at a very high risk for CVD or CKD, you put on all the 3 drugs in 1 month time. This is the current approach. Any addition from the professor?
No, I think you have answered that very beautifully, Professor Coco. And I'm sure, the cardiologists here will agree with me that even when you are treating, oh, sorry, the cardiologists, you will agree with me that even when you are treating heart failure, the traditional approach is one followed by the other. But John McMurray and Milton Packer have also suggested that if you need to urgently treat, and we know that the maximum benefit or the maximal benefit that you can obtain from most of our therapies, the 4 pillars anyway, in heart failure, it's second brittle valve Satan, it's a beta blocker, it is MRA, and it is an SGLT2 inhibitor. And they have recommended, as correctly pointed out by you as well, that in a month's time, you have to try to get all 4 different therapies, but you start at very low dose because they find that the impact or the benefit is actually quite good even at low doses. So if there's an urgency for you to control the patient's heart failure or the CKD, then you can take this so-called accelerated or alternative approach where we dose it in very quickly. So how do we do this in heart failure? Is because, when you start sacubitril valsartan, sometimes the BP tends to drop and the renal function suffers. So the easier or the more protective way is to start an SGLT2 inhibitor because it doesn't really make your kidneys function gets worse, and a beta blocker because it's very neutral to the kidneys. Later on, you could throw in SGLT2 inhibitor after the first or the second week. Sacubitril valsartan after the first or the second week, and finally the MRA. So these kind of things are there, these approaches are there. But I agree with you, Prof. Coco, this is a very individualized approach. So we have to see how quickly we want to get the effect and how the patient can tolerate these medications without getting worsening of their kidney function.
Thank you, doctors. Thank you very much.